go ahead with our next speaker. If there aren't any other, well, we don't have Giovanna here, and we get the good news is we'll catch her again, and we have her at the end for the panel discussion. So let's move on.
Kimberly, just a sec.
Yeah.
Do you want me to turn the video back on?
Well, I don't want to lose it again. I worry about that, but.
Hi, everybody. I don't mind as well just jumping in, and then maybe if at the panel discussion level, if the video comes back, we can bring it back. But for now is completely fine. So I hope that everyone can envision me waving to you.
Okay. I'll just introduce
I'll go ahead.
Yeah, I'll
absolutely, Kimberly.
Yeah, I'll just introduce you, Sarah, and you can throw up your slides if you like while we do that introduction, and we'll move on and hope to get Giovanna back for the panel. So really excited. Again, thanks to Giovanna, and great thanks for our partnership with the Occupational Cancer Research Center. You're going to hear more about that from Sarah. So Dr. Sarah Rhodes is an occupational epidemiologist, microbiologist, and advocate for community-driven research. She was trained at the University of North Carolina School of Public Health, where she conducted research in partnership with community-based organizations to evaluate the spread of antibiotic-resistant bacteria from industrial animal operations to workers, so neighboring communities and the environment. In 2019, Sarah moved to Toronto, where she began working with us at OHCOW to employ epidemiology as a tool for investigating the work-relatedness of our health concerns raised by rubber and plastics production workers in Ontario. In her downtime, Sarah enjoys spending time near the water, singing and Irish dancing. I knew we were kindred spirits, Sarah, and cooking delicious meals with family and friends. So please do welcome Sarah Rhodes.
Wonderful. Okay, well, thank you so much for that introduction, Kimberly. Good morning, everybody, and happy World Cancer Day. And thank you to Giovanna for that wonderful presentation and for starting us off and providing also an excellent context on rare cancer surveillance from the OCRC perspective and the Ontario disease surveillance perspective. And as Kimberly said, my name is Sarah Rhodes. I'm an occupational epidemiologist and microbiologist. I'm originally from the US, but moved to Toronto in 2019 and have been working with both OHCOW and the OCRC since that time, which has been so wonderful. And today I'm here to greet you all with the OHCOW cow doctor to try to identify and look more at these rare cancers or needles in the haystack of the Ontario worker population. So without further ado, let's jump in because we are going to look at the OHCOW lens of rare cancer surveillance. So what will we cover today? First, I'd like to start off with a brief introduction to rare cancer surveillance as well as epidemiology in Ontario. And then I'll look into OHCOW's role in this process. So we have a really broad landscape of surveillance and also looking at tracking workplace-related illness in this province. And so I wanted to do a deeper dive into OHCOW's clinic-based efforts. And the way that I'll do that as well is focus in on a case study that actually specifically works on a project that OHCOW has been involved in that's looked at a rare group of salivary gland cancers that have been observed in rubber and plastics workers. And then lastly, we'll close out with a discussion of some of these efforts that OHCOW has been doing to actually build our capacity for rapid detection of rare cancers in the next couple of years. So section 1, let's start off with rare cancer surveillance from OHCOW's perspective. So here's a question that I wanted to start us off with because I believe it provides context for what we're really all here for. And across the province, for a lot of workers who are presenting with suspected workplace-related illnesses, we're really wondering, is a specific occupational exposure or a mix of multiple exposures that someone might experience at work a significant contributing factor to rare disease development? And so this significant contributing factor language is actually the legal language that often goes into workers' compensation claims. And so we have a task at hand that really will be important to understand. And so in looking at this, we often at OHCOW are tasked with the process of looking at population level data. So with this, I mean that we're trying to look at population level risk. So on the population scale, do we see a link between certain exposures or maybe an occupation with a disease or illness? And then also we have to look at individual data. So you can imagine for us at a clinic like OHCOW, we have workers presenting and we have clinicians and occupational nurses, as well as hygienists, ergonomists who are working with them to collect individual level data about their health outcomes as well as their exposures. So we're trying to think about, for these specific workers, are they, based on their exposures at their specific workplace and the tasks that they're in charge of, does that have a link to disease development? So you can see that this is a kind of difficult task that we have to balance both population level data and individual level data to look at whether there is a connection between exposure or occupation and disease. And so more broadly, we have a lot of ways that we can be answering this question. One piece that often looks at the more population level is occupational surveillance, which Giovanna has so kindly gone over in lots of depth for us. So this is the systematic investigation of the occurrence of health outcomes in relation to working conditions. And I wanted to show you all kind of the variety of different databases that are available for us when we're doing occupational surveillance work of rare cancers, but also all cancers and also other outcomes. So we can look at cancer mortality, for example, looking at death certificates, but we also can look at the incidence of cancer or whether someone gets cancer but maybe doesn't necessarily die from cancer. And so some other types of data that we can look at are physician reporting data or patient registries. We can look at administrative data that is linked between occupation and also disease, which we see from the OCRC in the last presentation. The occupational disease surveillance system is an administrative data source. There's also other types of data like government population-based surveys that we can take advantage of and administrative data. So in this, surveillance is a kind of activity that is within a broader field of occupational epidemiology. So for those of you who may not be familiar with this field, I wanted to give you all a definition as well. So this is the study of timing, distribution, and cause of illness and injury that result from workplace exposures. And just interestingly, I wanted to take a pause with really thinking about the field of epidemiology and that this really did arise from our very human nature perspective of trying to make sense of different factors that might change the amount of time that we have to live a healthy life. So this aspect of time is really important. How much time do we have to be healthy? Does our workplace have an impact on loss of health, loss of life, et cetera? And so here, the occupational disease surveillance system is one example of this. So where does OHCOW fit in this broader picture in Ontario? It might be fairly simple to guess, but we do fall here under the more clinic-based approach and going through with physicians reporting and patient registries. And as I mentioned before, OHCOW is unique because we can collect data that is both diagnostic but also exposure related. So having this unique one-on-one interaction with workers who are presenting because they do have a suspected workplace-related illness and they're looking for help, we're able to actually collect data that is both diagnostic and as well as exposure related. So that's a very exciting piece of what we do at OHCOW. And so how does this process really work for us in looking at early detection of rare cancers in our clinics? Giovanna provided the definition of rare cancer being less than 6 cases per 100,000 population per year. So you can see that's very, very rare. So for us today, I'm going to walk us through the process that OHCOW takes to do some of these investigations that we do. And one of which, and the example I'm going to follow, is actually a case of rare salivary gland cancer that we observed among rubber and plastics workers. We're currently under investigation of this, so we aren't yet ready to present the exact specifics of our results. So I wanted to still show you the process that we follow. So I've prepared an imaginary example, but just to also make the point of what we're doing here. So let's all imagine that OHCOW physicians detect a group of 5 cases of salivary gland cancer among a total of 1,500 plastics workers who have ever worked at one factory over 10 years. So in this case, we have a low number of cases, so 5 cases. But interestingly, for OHCOW, because of the nature of what we do, we often have workers who may be from similar industries, that have come together and even in discussions with each other said, I think that I might be getting sick because of the work that I'm doing. What do you think? And if they're talking to other workers, maybe presenting together or separately to the OHCOW clinics. And so sometimes we do capture that there might be up to 5 cases of a rare cancer that present to OHCOW, all from the same industry, and also from a kind of smaller catchment of workers than, for example, 6 cases per 100,000 population per year. So even though we do need to do a deeper investigation after this point, even seeing these cancers at all in our clinics is important for us to note and important for us to take a deeper look at, given the rarity. So let's keep moving. So where do we go from here? We have workers presenting to the clinic. We have a first catch of these groups of rare cancers identified via what we call intake clinics, which might be clinics where we collect data from workers related to their diagnosis as well as their exposure. And then we generally follow different types of investigations from that point. And the top here you'll see is an exposure or hygiene assessment. So this is an investigation really actually exposure focused. And then we also can make connections with other groups like the OCRC, like Institute for Work and Health, to do broader investigations that actually look at the ODSS, for example, to say, okay, we see salivary gland cancers coming up at our clinic. What does that look like on the broader level at the level of the ODSS? And that's an industry or an occupation specific general or kind of larger population study. And then lastly, say we see cancers coming up at a specific workplace, we can also pursue potentially a workplace specific study. So before we continue on, I wanted to just show you a couple of photos, given that we're focusing on plastics and rubber in this particular example. And so here on the left, just for context of the Ontario industries, we have plastics industries such as here, we have car bumpers manufactured at Venture Plastics, Peterborough, Ontario. And then on the right, this is a historic photo that I came across in an article of Dominion Tire, which is a rubber factory in Kitchener, Ontario. And you can really see how long the rubber industry has been in this area, given this photo. So I just wanted to show you that and put some images to the industries that we're talking about here. So let's get back to our 3 different investigations. So first, we might decide to start with an exposure or hygiene assessment. So what is this? This is an exposure related investigation. So we're asking, are these workers exposed to what? How much? How often? For how long? So these are types and magnitude, duration of exposure by specific job tasks, by department, etc. And we really do at OHCOW need to have partners for this work. For example, we might partner with Unifor or a union to be able to work with workers and get in contact with workers, to be able to do interviews, to understand more about what their specific jobs are like, as well as the exposures that they experience. If we don't have as much access to types of information, we also can maybe access reports through the Ministry of Labor, where we can look at inspection reports or other data sources to get a sense of what exposures might have been occurring at the plant. And then these exposure assessments we can do at varying scales. So we can do this for one worker at the individual level. We can do this for groups of workers. So for example, say we had a group of salivary gland cancers in rubber workers and a group in plastics workers that were showing up. We might want to say, okay, we see that this one diagnosis is coming up in these workers from these different industries. Do those industries share specific exposures? What is this kind of middle ground of where the yellow star is? And then lastly, say we see that all of our cases of salivary gland cancer that we see are coming from one workplace. So you can imagine each of these boxes is one specific plant. We might want to look at an exposure or hygiene assessment that focuses in on that one specific plant and what the exposures were like there. And so next I wanted to speak for a moment about the process that we follow to really ensure that we're getting this information out to the public, as well as to other research institutions and other people involved in workers' compensation in Ontario, as well as in occupational health and surveillance in Ontario. And prevention, I think that's one that I always want to be sure to mention as well. So first and foremost, we might say for the specific worker, if we have one worker case that seems really interesting, that has detailed information, we might write a case report, and this is what that would be called, and publish that information. We could write a case series, which would really be doing that comparative work of comparing different groups of workers and really having very extensive exposure information. That's really critical, that we do really extensive exposure assessments for these groups of workers to be able to, one, be able to also compare to what we see in the literature, as well as what we see in these specific workers. And the case series history is actually really interesting. OHCOW, as well as historic clinics, but as well as occupational physicians, have played a huge role in continuing to kind of have an initial signal that then it was taken up and continued on through epidemiologic investigation, through animal toxicity studies, that will then lead to, for example, a removal of a toxic agent from a workplace. So I pulled one example here from the historic rubber industry. Here is Dr. Ludwig Renn, who's a German physician who in the late 1800s had actually written a case series because he was seeing and observing bladder cancers amongst rubber workers who were exposed to aromatic amines. And this initial case series work that he had done was published and then taken up by others to do more animal toxicity studies as well as epidemiologic investigations, which you can imagine as that keeps going and more investigations occur, eventually there was a connection made to beta-methylamine. I apologize if I'm mispronouncing that, but all that to say, it was a very, very large motion in this industry in the 1950s, I believe, which was something that was a huge preventative measure related to bladder cancer. So at OHCOW, we also are trying to ensure that if we do have case series coming forward, that will be sure to share that information and call for further investigation. And then lastly, we have the example of a workplace. So here we can see, actually very recently, there was a specific exposure profile done for the plastics plant in Ontario, Ventura, formerly known as Pibra. And so if you all would like to take a look at something like this, on the OHCOW website, you can access this a recent exposure profile that was done for a specific plant. And this was conducted by Unifor and workers, as well as a couple of academics, the DeMattios. So you can look at this online on the OHCOW website. Next up, I wanted to highlight the role that OHCOW plays in kind of, as I was saying, starting off with recognizing these groups of cases that have maybe suspected workplace relatedness, and how we then here usually play a role to kind of sound the alarm to other groups to say, we're seeing these cases, and these are some of the exposure trends we might be observing. Can you look at this at a higher level, at a more population level? So for this, like I said, we definitely need partners like the OCRC and others, and the Occupational Disease Surveillance System is such a huge tool that is very necessary to help continue to do kind of back and forth checks between, like I said, and either individual level data, smaller group level data, and population-based data. And so we can ask a question of, specifically for salivary gland cancer, a rare cancer that we're observing in workers, what does this look like on the whole industry or occupation level? So we did in fact have this occur. And so there's been conversation back and forth between OHCOW and the OCRC, and the OCRC did end up publishing a paper on this exact issue of cancer surveillance amongst workers in plastics and rubber manufacturing in Ontario, here by Dr. Nathan DeBono. And so this paper does highlight some of the broader cancers that we're seeing amongst these workers. But for reasons like Giovanna had highlighted, there's issues with small numbers and also rare cancers. So oftentimes, unfortunately, sometimes those do not end up in the published literature. However, in this case, we were able to connect with the OCRC, and at the industry level, so the highest level, we were able to look, and you can see here that we have an interesting initial result of 15 cases of salivary gland cancer observed among rubber industry workers. And so this is rubber specific, but you can see there's a modest elevation, the hazard ratio of 1.32, which as in epidemiology, we would describe as the rate of salivary gland cancer among workers from rubber industries was 1.3 times that in other workers in the ODSS. So this is compared to other workers in different industries. And something I'll note here is that this result is one that's interesting because like Giovanna was saying, we have struggles with reporting out and interpreting data that's based on such a low number of cases. But also what's difficult in the literature sometimes as well is that we only often present some of these either hazard ratios or other sort of metrics if they are statistically significant. So oftentimes you'll see this written if you're familiar with the scientific literature or even just processes in scientific methods. And that would mean here that if you see here, we have a hazard ratio of 1.32 with a 95% confidence interval that goes from 0.79 to 2.21. So for something to be considered statistically significant, generally you'll see that the confidence interval is above 1. So for this metric, it does go below 1 for 0.79 to 2.21. So it's a more imprecise metric. However, what is interesting is that oftentimes it is still really important, especially with rare cancers, to be able to look at these types of results because they are some of our early signals of saying, oh, here's something that we do see a slight elevation with a broader confidence interval, but something that is important for us to keep looking at and to better understand and continuing to look at other sources of evidence as well. So it does involve a bit more triangulation, but it is really important that rare cancer data is actually reported if possible, given the privacy concerns that Giovanna had very importantly noted. So with that, we'll continue to the next piece, which is in our investigations looking at the industry level, so what we just talked about, doing an epidemiologic study at the more industry and occupation level, but what about the workplace level? So for us, if we do see that certain cases, for example, salivary gland cancer, are coming up at one specific plant, we would have an interest to say, okay, can we actually do an epidemiologic study at the plant level that would look at workers for that specific plant? Are they at a greater, do they have an elevated risk when compared to other workers in Ontario? So we again need partners to do this. So for example, for some instances, we have to partner with unions who are able to also provide lists like seniority lists or data about workers that then can be linked to data like the Ontario Cancer Registry, which is why I've listed the Cancer Care Ontario here. So it is really important for us to have access to data that can be, providing information around workers who worked at specific plants, who were in specific departments, and being able to link that to broader databases that we can do investigations like this. However, there are a lot of challenges to that, especially for rare cancers, which I'll discuss next. But this is something that OHCOW also tries to pursue if possible and definitely needs partners to work on this. And so this slide here, I wanted to, as we get close to wrapping up, I wanted to speak a little bit more to this plant-specific study feasibility. And I think it's important for us to talk about because when I see that there's an annotation request, I'm going to say yes for this moment, and then we'll keep going, but I will do this. And I'm also sorry, everyone, I cannot see the chat at this moment because of the screen share.
No worries, Sarah. I'll keep a look for you. Not a worry.
Okay. I'm not sure if this, I'm going to close the annotation just for now because it seems like it might distract. So I'm sorry. But for this slide, I do think it's important for us to talk about these kind of plant specific, oh goodness. Okay, I'll approve one more time. I'm getting another request to annotate. So in this specific slide, I'm talking about the components of a plant-specific study. So if we have one workplace that really is showing that there might be an elevation of specific cancers, what do we need to consider, especially for rare cancers where there might not be very many cases? And also for a certain plant where there might not be too many workers in that population. So just right here, I wanted to mention some of these pieces when we're looking at doing a feasibility. A feasibility study is what we call it, of being able to determine, can we do a study like this? So we need to consider the sample size. So how many people are there who work in the whole plant? And we look at the cumulative total number of workers who worked at a specific plant over time. And then also, do we have enough cases to protect privacy, to be able to estimate relevant measures? Do we have data? So if we look at the data on workers, say we have worker data that we're able to use? And do we have the ability to connect that with their departments or their job tasks? And then also expected rates. Can we actually look at how many cancers might we expect to see in this cohort based on what we see in, for example, the general population or otherwise? And then lastly, data protection, which I formally mentioned. For specific plants, there can be some barriers to analyzing data and storing it and protecting workers' safety in that way. And so we also need to consider, especially at OHCOW, what partnerships we need to form. So with that, I'm going to move to section 3, and I'm going to actually close back this annotation to keep moving. So to close, I wanted to follow with some of the efforts that OHCOW is doing to continue to build our capacity to detect rare cancers through OHCOW, and also to continue to work in partnership with other groups in Ontario in the broader landscape of surveillance. So one of those actually is to continue to clean and restructure our databases at OHCOW, because like I said before, it's a unique opportunity with both clinical data as well as exposure, really detailed exposure information. And if we were able to bring those things together, that can be very powerful, and especially ensuring that that data is collected systematically over time. We can potentially even look at doing analyses like case control studies within our data sets, which would allow us to say, okay, we have a certain number of cases in this data set, we can match to what we would call control workers, who would be workers with non-cases. So there's some expansion here possible. We'd also like to keep strengthening our partnerships. It's been so valuable to be able to work with the OCRC as well as others, and especially with working with unions and workers, being able to get firsthand perspectives on what workers are concerned about in the workplace. And then lastly, I think there was some questions going around about what can we do to continue to share this information out broadly. One area is that we really do want to keep educating, especially around rare cancers, educating workers and continuing to also do more work around these rare cancers in regards to literature reviews and having a deeper understanding of the mechanisms that lead to connections between exposures and disease, as well as doing some more education work with medical professionals about rare cancers, because oftentimes, and this is a broader problem, we know that medical professionals outside of the OHCOW system don't have occupation at the top of their mind. So it is useful, and we've had some conversations around other illnesses with doctors at Sunnybrook Hospital, etc., to really let them know, these are things that we've been thinking about, and ask them if they've seen any connections or have any sort of tracking of occupational connections. So we want to keep doing this work, and it seems like there is a bright future, especially if we can all continue to keep building these partnerships and really take advantage of the perspectives that we all bring to the table. So with that, I'll close. And if anyone has any questions, please do let me know. And thank you.
I'm going to give a shout out to Sarah for so many things, but for all her work here, joining our multidisciplinary, interdisciplinary team of with this work from an epidemiological perspective, and having the strengthening that physician, nurse, occupational hygienist, ergonomist, client service coordinator, interdisciplinary team, what Dave's going to talk about next. But that was her idea for the title for the presentation, and needles in the haystacks with the rare cancers. So I wanted to mention that, and Andrew too. Andrew Zarnke wanted to shout out for the idea to talk about the rare cancers that he's working so hard on with our team. So, and maybe just before we move to questions for Sarah, we did have one for Giovanna that I wanted to bring back up, and just to back from Daryl was asking with the surveillance database. Hi, Sarah.
Hi, everybody.
If the NAICS and NOx codes were used for the occupation and sector.
Yeah, thank you. Sorry, everyone, my internet disconnected, but I guess I made it through the presentation, so that was okay. Yeah, so we actually use the CCDO coding, so the Canadian Classification and Dictionary of Occupations. And then for industry, we used SIC 70 and 80, so the standard industrial classification. So that's sort of been the standards that we've been using, just because it's been easier to code with the WSIB coded occupation and industry, which are also SIC 70 and 8, more recently 80. So we have just been using those for coding.
Great, thanks. Thanks for that. And do you want to make some comment? You had quite a few comments in the chat. You're welcome to unmute anyone who would like to verbally ask a question of Sarah, and we're going to have Dave Wilkin present next.
And everyone. A question then.
Yeah, go ahead.
So I put it in the chat as well. These are both tremendous high quality presentations. Thank you very much. Something we've encountered a lot at the front line, two related problems. First is, usually, I'd say more commonly than not, we detect these situations at the front line long before any scientists get involved. So just like I think was being said by one of the presenters, workers notice that a lot of people are dying from something or other. And a common problem is that the data we have access to might tell us, I don't know, in the case of a big factory, 8,000 people have worked at this factory over a period of 50 years. And yet, so then some kind of epidemiological work gets done, and we find that there were X number of some kind of cancer among those 8,000 workers, and the excess risk was only like 20%. But actually, for anyone who works in that factory, they know that it was only 1,000 of the 8,000 who actually got exposed to any significant extent to whatever carcinogen might have caused those cancers. So suddenly the risk for those 1,000 compared to community levels or levels in general in the population is really significant. And it's been a tremendous barrier. And we've got all these studies the employers rely on, which are sort of along those lines. And I'm wondering what kind of approaches you're using to go deeper and what kind of information might be in standard data sets. And I'll just mention one more. A beautiful study was done of the Elliott Lake uranium miners, and it showed virtually a dose-response relationship between exposure to radon and lung cancer. It just went up and up. The more exposure, the more lung cancer, essentially. And however, that kind of data is very rare because there you had actual exposure records from each individual worker, and you could match it up with their health records, and they did it for over 30,000 people. It was a powerful, beautiful study done about 10 years ago. So I'm just wondering what techniques you're using. How are you digging into these rubber workers to see whether it's a pool of 1,500, in which case you've got a certain, whatever level, versus maybe is it a pool of 500 who were most exposed to the toxic mix that probably contributed to this. So just throwing that out, it's a huge challenge in all kinds of situations.
Well, first and foremost, thank you so much, Alec, for your question, because this is, as you said, a huge, huge issue. And it's something that is across the board, I think one of our largest concerns around being able to conduct these investigations is especially, at the broader level. Even for the ODSS, it can be challenging because we have a broader surveillance system, but that doesn't get at the finer exposure details. So we really, I think that's the exposure side is something that we're really trying to focus on. And I think that's, for me, from the past work I've done when I came across OHCOW, I was really, really interested in the work that OHCOW was able to do because of the ability to both connect with workers who, like you said, I think in my past research experience, I've seen that either community members or workers kind of come forth with their concerns, and that can be some of the first signals that are really important. And also they have a lot of knowledge around what they're experiencing in their own bodies that they're able to share. So I think this is something that we've been asking ourselves, especially with the rubber and plastics workers, of trying to say, even for the exposure profile that was recently done for the plastics industry, I think that kind of work is a great place to start for the exposure referencing, because oftentimes, especially, it is really challenging, even with union data, where we can say, okay, you know, even if we have a seniority list or some other form of data that might have linkages to exposure information, usually it's no more detailed than just at the department or job task level or job title. So we'll have those to link to, but we do really need more information. And oftentimes it is interesting because that usually, I think the best source so far that we have is to work and then better understand with workers through focus groups and otherwise. But for the rubber work, we have been finding ourselves definitely needing to do more detective work, which I haven't been involved in quite yet, but I'm just trying to get access to other records that show information about exposures, but also looking at doing work with the workers that we see, especially for rare cancers. If we can do these case series like we're looking at, Andrew Zonke, who's on the call, and others have been doing a lot of this type of work where we can say, okay, we're seeing maybe more rare diagnoses, and what can we do to do the most detailed exposure assessment that we can for those specific workers, to get a first picture of what the exposures are, and then also be able to match that against the literature. But there's a long way to go, and I think that there's a lot of need for this, and this is where I've also thought about OHCOW with kind of the long-term data lens of even the data held on site at OHCOW, because there is an ability to, if we can track workers that are presenting to the clinic, as well as their exposure information, I think that there's potential to be able to say, okay, we have cases that we're able to draw from, but also we have other workers presenting to OHCOW that could be used as control samples. So there's this ability to look at more of a comparison of like exposed versus unexposed, which would be really interesting. And one, like you said, that ideally we would like to be able to also look at internal comparisons within the same plant of saying these workers were highly exposed. How do we compare them against workers who were lesser exposed in the same plant? So all that to say, I'm afraid I don't have a golden ticket answer to your question, but I do think that there are a lot of efforts within the OHCOW teams to really put our heads together to think about the best ways to both try to conserve data that exists as best as possible, while also trying to think through new ways to analyze and really consider the exposure levels. So
thanks, Sarah and Alec, and yes, just piece together a couple of the other comments in the chat. Kevin with similar exposure groups, and you know, all that we're talking about with exposures in general. It's, you know, what's really important is you all have a part to play. Carmel mentioned it earlier. How do I get people, you know, how do I, you know, this is occupational cancer is the leading cause of workplace fatalities. It's 1 in 5 cancers are occupational related. So the way that you can all help is to be tracking your exposures. You know, just like you track a CV, and we're hoping to bring you more about that later, but you know, you should, you know, we're interviewing workers that are trying to remember what, you know, what chemical they put where, and you know, how they did their work on a day-to-day basis. And so, you know, all of this comes together. And just like with prevention, if you want to hear about a hazard and how to control it, you talk to the worker. Well, if you want to hear about what they are exposed to, you know, you talk to the worker. So yeah, thanks to both of you. I think we wanted to take a stretch so everybody get up and move around. And Sarah's staying, as is Giovanna, but I think we'll let Dave present now and come back to the panel discussion and have more chat and input at the end here. So so make sure you we were going to take a small break to get up and stretch, but please do so on your own. And